Agora já estão me vendo já.
Já estão te vendo? Quando você quiser, você liga o seu microfone e a sua câmera. Pessoal, acho legal fechar aqui, ó.
É isso aí. Hello, guys. Welcome to this session. It is a pleasure for us from ImplantePerio to be with you this afternoon here in Brazil. It's going to be a different activity because this is actually the first time that I ever do this activity here, like narrating a surgery. So we are very used to do like commenting the surgeries, but now narrating it is going to be the first time. But anyways, Paulo is already with the patient there, and this patient has received one implant 12 years ago, according to her. As she can remember, between 10 and 12 years ago, she fractured the tooth and had it removed and performed an immediate implant placement with immediate temporization and, according to her, a connective tissue graft, some reconstruction that she did there. Through time, she lost the volume, and they tried to repeat the grafting a couple of times, but none of the times with good stability. So she finished the prosthesis, but as you can see, we have a small recession and an obvious loss of volume. I think you could see that also in the image that we provided you at our WhatsApp. So you can see the occlusal shot there and the pictures in which it is obvious the loss of the volume. When we see the CBCT of that patient, it seems that the bone is very thin, or we just don't have any bone in the buccal area. But there is no proven depth, so there is no pathology there going on. So as our protocol would indicate, we're going to go for the introduction of a connective tissue graft to boost the tissues in a way to create the volume that we want, associated with some coverage as well. Prior to this procedure today, Dr. Vitor Clavijo, he did like he removed the prosthesis for us, which is screw-retained, as you can see here, and he reduced a little bit of the volume in that area to create some space in a way that Paulo now can perform the connective tissue graft and have the space to keep it there without putting pressure on the cervical region. So Paulo now is exactly showing the space that Vitor tried to create after he removed the prosthesis. And we can see here clinically that hello, Robert, audio, image. Oh, thank you, Richard. Guys, if you have questions, please send them here to me so that I can try to answer your questions, and let's make the best of it, okay? So I really hope you enjoy this activity that we are doing for you right now. So in the occlusal shot, you can see that we have a very thin soft tissue, okay? We have a volumetric deficit in that area, but the papilla seems to be just fine. So it is merely a buccal improvement. But maybe Paulo can try to increase a little bit the base of the papilla. Let's see how he's going to perform the procedure. So the patient is already anesthetized, so he can just start the procedure, and basically we can start by preparing the site, or he can start grabbing the connective tissue. It's pretty much a momentary decision, but probably here Paulo is going to create the space first, and then he would get the connective tissue graft. Okay, for that regards, for creating the space, he's going to use this micro blade from Surgistar, which is like angled. I personally like this one very much. Other people like another brand of micro blades. I like this one better because the shank of it is not very big. Another brands, they have a very long shanks, which makes sometimes a little bit more challenging for us to reach the area. This actually is the final prosthesis. Okay, so the prosthesis was done already, so it was a final prosthesis. But what Vitor did was to remove the crown, which was screw retained, and using those specific burrs or whatever, he removed a little bit of the volume in the cervical area. But that is actually the final prosthesis of the patient. Okay, so now we are going to start performing the site preparation, and you can see here that Paulo is about to start using the micro blades for that, and that is a major difference between a tooth site versus an implant site. Because when we are working around teeth to do this modified envelope technique, we always start using a full thickness flap elevation, using the tunneling instruments, okay, because it's full thickness. But when we are working around implants, because in the area buccally to the implants that we don't know if there is bone or not, in that area, most of the times we go with a micro blade, because we don't want to challenge the threads of the implants that supposedly are exposed to that environment. So we like to do like a sharp dissection, but it's not like a real sharp dissection, so to speak, because the blade is almost touching the bone or the threads in a way that the outer flap is as thick as it can be, with a small area of connective tissue covering the threads of the implant. So we call actually that a supraperiosteal flap elevation. So when we are doing this tunneling instrumentation around teeth, we're going to use full thickness elevation until we get to the alveolar mucosa. Okay, and in the apical area, of course, we can dissect that area. So that is like a mixed flap elevation. But when we are working around implants in a situation like that, we don't know if there is any bone present in that area. So therefore, we're going to start using the microblade inside the gingival sulcus, as you can see Paulo start doing, very close to the bone, in a way to create the space without putting any kind of pressure on the threads of the implant. Okay, so we don't want to challenge that area, so to speak. You can see that Paulo is starting very, very slow, but you can see how easy it may be, because he's already beyond the mucogingival line at that area, creating the space, for the placement of the connective tissue graft. We have to be especially careful here at the mucogingival line, because there we have a different kind of insertion of the fibers there. And if our assistant is not putting a lot of pressure in the cheek retractor, okay, it can create a fold in that area that the blade can go through in that fold. So it's really important that our assistant is putting pressure on the cheek retractor in a way to expand that area the best way possible, with the objective of facilitating the dissection of the alveolar mucosa. All right? So you can see here that Paulo is already beyond the mucogingival line, and basically he's trying to find those attachments, the tissue adherence in that area, and he's cutting them with the microblade. So you can see that the motion of the microblade is like this, mesial distal, and the tip of it is finding those fibers and breaking them, like rupturing them, tearing them, cutting them. And it's also important that you understand that we must have one plane of dissection. So it's very important that you have only one plane of dissection. I say that because sometimes when if you start one plane here, then you start one plane there, and they are not necessarily at the same level. So it's really important that you are able to go from one side to the other in one single shot, in a way that there is only one plane in that area. So also very important and critical to do this maneuver in the area of the frenulum here, because that area we have a lot of muscle pull because of the frenulum, and there's like a groove in that area in the bone. So a lot of adherence there of tissues that are sometimes a little bit challenging to be, cut. Paulo is showing that specific area is very thin, so have to be very careful with this procedure. So take your time to do that. You can see here in this area towards the distal, in the base of the papilla here, we still have some attachments there. So now that he went in the apical direction, now it's important that he starts dissecting in the base close to the papilla. Okay? So you can clearly see Paulo trying to find the last fibers and cutting them with the microblade. And this angled one is specifically more suitable to this procedure because of the angle can facilitate the angulation towards the fornix. And during this maneuver, Paulo is always trying to check if the tissue is already mobile, because we want to create a space, but also bring the tissue in the coronal direction. You can see that using the probe, he's pushing the tissue down to see if the gingival margin is being mobilized. In the base of the papilla, it might be exactly that Paulo can use the tunneling instrument, because now he's going to be on the tooth side. So on the buccal area of the implant, you could perfectly see that he was using the micro blade, but towards the teeth, he can change gears and utilize the tunneling instrument. And in a given moment, he's going to find the bone, try to find the bone to make the contact between the instrument and the bone, and that part will be full thickness flap elevation. Okay? And it's very important that he does that in the base of the papilla, because if he doesn't create the space there, he's not going to be able to place the connective tissue at that specific region, which is the base of the papilla. And that seems in our experience as educators, as teachers that perform a lot of procedures with students, the number one mistake in the creation of the space is exactly at the base of the papilla adjacent to the site, because the students, they are afraid of breaking the papilla, so they are a little bit more conservative. But if he doesn't create the space in the base of the papilla, it's impossible for him to position the graft where he wants it to be, which is at the base of the papilla, right? You can see that in the papilla in the center, he already has some space there. In the base of the papilla, as you can see. So the probe is also interesting to find the attachment there. It can be Richard. So Richard is asking if the base of the papilla is full thickness. It can be, because there is bone there. So if we find the bone in the base of the papilla, we can go either with the microblade or we can go with the tunneling instruments. So it can be full thickness in the base of the papilla as well, or he can just continuing doing the sharp dissection in the base of the papilla. But I would say that it's easier for you guys to detach the base of the papilla using the tunneling instruments. Okay? So it's safer, so to speak. So you can see the mobility. So this area that is showing, I'm pretty sure that he has to work a little bit more on that area, because I don't see the mobility that I would like to see there. So you can see now that he's working with the micro tunneling instruments, and here he's trying to find the bone, okay? Because it's a tooth site, not the implant site anymore. And in the base of the papilla, trying to get to the bone. And this is a danger zone, okay? Because it's very easy to perforate that. So have to be especially careful in that area. So he see that he's trying to get the interface of the bone to pull the tissue outside, like a full thickness elevation. So we have different instruments in the kit. So you have to use different tools. Sometimes the angle of one instrument is better than the other. So it's a matter of trying to use the instruments the best way you can to create the space that you need. So in the apical part in that area, it might be there are some attachments there. Now he's moving from the gingival sulcus towards the tunneling that he created underneath that papilla. So being very careful. See that now he's changing the instrument. You can start seeing that the papilla is starting to move a little bit more, but yet I think he can work a little bit more in that area. So probably he has to really see the tunnel being created from the buccal area towards the apical part, going below the papilla. So if he can create that space, the papilla will be moving much more because he will be detaching the base of the papilla. Okay? And that will create the space that he requires for the placement of the connective tissue in that area. Have to be working with a lot of caution there because the soft tissue is very thin and fragile. And see, here is trying to create that space that I told you to connect, so to speak, the tunnel below the papilla level. He's using the probe, trying to find some fibers there. In specific cases where things are becoming more challenging for us or more difficult, we can have the benefit of performing one vista incision. So the vista incision is like a vertical release and incision in the alveolar mucosa, distance from the area that we are working. I would say that, for instance, if Paulo was getting some hard time trying to do that, he would perform a vertical release incision here between the lateral and the canine in the alveolar mucosa in a way to create a space laterally. But I don't think Paulo is going to be requiring that because he's almost done already. So it's a matter of some fine tuning there in the detachment, and he's going to be very, very quickly finishing the tunnel, the modified envelope flap. See that Paulo is still working a little bit in that area, in the base of the papilla. So he's taking his time, being patient in a way that he's happy with the detachment that he is getting. See, now the papilla, the tip of the papilla is already moving. Sometimes when I'm doing this procedure here, I like to use the microblade like in the base of the papilla internally, almost going from the base of the papilla to the tooth, like this, in a way that I can connect the tunneling that he did from the tooth towards the base of the papilla. So I think that sometimes that gives me the extra space that I need to really connect everything. So I personally like doing this kind of maneuver that I just described, and that is using the microblade in the base of the papilla internally towards the tooth. And that creates the space that I need to engage the instrument and finalize the tissue preparation. The instrument that Paulo is using right now is one specific instrument from the tunneling kit that is distributed by Helmut Zepf. Okay? This is the papilla elevator, the name of this instrument, which is one instrument of the tunneling kit that is distributed by Helmut Zepf. You see now that the tip of the papilla is moving much better and almost ready to go. So during this procedure right now, the students that are in the lecture room are asking him questions, and he's replying, responding those questions as they come. And they are now asking him, how is he sure that the tissue is completely, loose? And he's demonstrating with the probe that there's only one plane of dissection, and when he puts pressure on the tissue, it moves. So that's how we know that we are done with the procedure. He's saying that that area super thin. So that is a danger zone. So Richard is asking about what is the tip when we start doing that, and you find two planes. So Richard, what you have to do is find a way. If it happens, it may happen, but then you have to find probably the deeper plane, okay, which is associated with more thickness of tissue, and try to connect everything with the microblade. So typically what I would do is using the microblade again and try to connect everything in one single plane. Okay? This can happen, but if you practice a little bit, if you do two or three cases, I'm pretty sure it won't happen. So right now, Paulo is positioning again the provisional restoration, and he's checking if with the pressure he can mobilize the tissue in the coronal direction. He might even reduce a little bit of more of the volume there in that area if he feels like, but since what happened here, Marcelo. Okay. But Sorry, guys, something happened here. Okay. So I don't think Paulo is going to change anything because that is the final prosthesis. So ideally, we would be doing this with the provisional restoration, okay? And in the future, when the soft tissue is already stabilized, then he's going to finish the case with a final prosthesis. So this case here is like a very specific case in which the prosthesis was done already, okay? So we're going to try to save the prosthesis for the patient, and Vitor decided to remove what he thought it was required for stabilizing the height the best way possible. So after Paulo finished the site preparation, he now anesthetizing the palatal area. So in a case like that, ideally, we prefer the tuberosity, right? But the patient doesn't have a good tuberosity to work with. So therefore, we're going to take the graft from the palatal area. So Paulo measured the width of the graft that he requires, and that is from the base of the papilla to the base of the papilla. So that is the dimension mesiodistal of the graft, from the base of the papilla to the base of the papilla. Then, in terms of the height of the graft, he's gonna probably take like 5 to 6 millimeters of height. We don't have to take bigger or more wider grafts in that area. So he's going to take a free gingival graft, and then he's going to deepitalize this free gingival graft to take the lamina propria out of it. So if I have the tuberosity, that would be my number one alternative. If I don't have the tuberosity, my second alternative is taking a free gingival graft to deepitalize it outside the mouth. Because by taking a free gingival graft, we have two advantages in this kind of procedure here. Advantage number one is being more precise in terms of the dimensions of the graft that we want to take, because it's always easier to take a very regular shaped free gingival graft as opposed to a connective tissue graft. So that is advantage number one. And the second advantage would be to take the best part of the connective tissue graft, which is the lamina propria, just below the gingival margin. So we have lost the image here. So just a second. I'm going to check what happened. Just a second. Okay, guys, it's coming back. So we had a problem there in the camera, but now Marcelo was able to reconnect. And there you see the trap door, which is one incision in the base of the papillas there, maybe 2 millimeters away from the base of the papilla, and then two vertical release incisions. Two vertical release incisions there. And now he's elevating that like a trap door. Okay? And as you can see, Paulo is able to remove a very regular shaped graft. which is very convenient. And number two, he's going to be able to take the best part of the connective tissue, which is associated with the lamina propria. So after he elevated the the trap door, now he can connect the base of it. And in this patient here, after he removes the graft, it seems that she has a very glandular and fat tissue. So imagine if he was trying to get the connective tissue with the singular incision, he would probably not get a good connective tissue graft. So it was very smart and convenient in this case to really take the free gingival graft, because he's going to take the best part of this connective tissue, which is just below the lamina propria, just below the epithelium, which is the lamina propria. You can see that when we have like a glandular and fat area, it bleeds a little bit more, okay? So the quality of the deeper portion of the palate there is definitely not good at all. So that's why, number one, for implant sites, we like to use the tuberosity. But if you can't work with the tuberosity, because this patient, she doesn't have a tuberosity to work with, then the second alternative is the free gingival graft to de-epithelize it outside the mouth, because number one, we take a very regular, well-shaped free gingival graft. And secondly, we're going to always have the lamina propria to work in that area. Now, he is positioning there a collagen sponge, and he's going to create a suture in that area. So he goes in the base of the papilla, like on the long axis, the palatal, the mesial distal aspect, and then he changed the direction to the base of the papilla. So this is a so-called Y suture. So very easy, very fast, and very convenient and very effective. So Richard is asking again here, what is the thickness in terms of the graft? So for a tooth site versus an implant site. So when we are working, for instance, with a root coverage procedure, so with around teeth, so basically we think about a graft of 1 millimeter. It's good enough. Okay, 1 millimeter thickness graft. I mean, the part that is going to be positioned there, of course, under the flap. Okay, but if you are working around implants, especially because of the volume loss that the patient has, so we're going to take probably 1.5 to 2 millimeter thick graft to position that area. All right, so a little bit thicker to implant related sites as opposed to a tooth related site. And remember, Richard, that this case here, Paulo still have to remove the epithelium layer.
Quando você cair de novo, eu vou descompartilhar e fica você full screen. E aí eu desligo, já ligo de novo ela volta. Tá bom?
Tá. So it seems that we are having some issues with the camera. It's coming back and forth. So probably Marcelo will disconnect the camera and start over the process here. I'm sorry for that, guys. But anyways, what Paulo is doing right now, you can see quite clear. He's just putting some pressure in the palate to stop any bleeding that is there and finishing the sutures. Okay? And after he does that, he will be able to position a layer or two of cyanocolate, which is adhesive, okay, tissue adhesive, to really seal and block any blood clot to get out of that area. And that also will provide some extra comfort for the patient because there is no connective tissue exposed in the palatal area. So that is super convenient, super easy. I know that right now there is a kind of movement towards placing like composite, flowable composite in the palatal area. If you can do that if you want, but honestly, it's more expensive if you compare the price of the tissue adhesive versus the price of the flowable composite. So number one, the cost, and number two, that it's very easy to detach it from the mouth. So if there is any kind of pressure in the base of that flowable composite, it can detach a little bit, and that will create pain for the patient. So honestly, I think that the cyanoacrylate is the best alternative to seal and protect that area. Okay? Okay, Michael, thanks. You're saying that the translation is better to understand the steps. So Paulo is doing a live surgery, guys. So he's explaining everything in details to the other guys in the lecture room. So trying to show the step by step. But in your office, this is way faster. When we are doing that in our offices, it's way faster because we are not concerned about showing anything to anybody. We just go with the flow of the procedure, and it's super fast. So very, very, not very difficult procedure to be performed. So if you practice, of course, so that is part of our everyday procedure. So there's not a single day in my office that I don't take a connective tissue graft, for one another application, and we do exactly what Paul is doing right now. So this is like everyday work. So it's super fast because you practice a lot and you incorporate that in your everyday life. So there's no challenge doing this kind of procedure after you get the feel of how it's performed. So he's going to try to show you now the palatal area. So 4 sutures completely sealed. You could also see the clinical reality of the timing. So the removal of the graft, we really don't take more than 3 minutes to take the graft. Any graft, pre-gingival graft, connective tissue graft. So less than 5 minutes, so to speak. And you can name the size of it. We're going to take it in less than 5 minutes. But in terms of the suturing, it's like at least the double of the time to have it sutured. Okay? And now Paulo is placing the cyanoacrylate on top of the area. So there are different ways of doing that. You can use this kind of bottle, plastic bottle, that I personally don't like. I prefer to use like flap uh, some instrument like a mold, okay? And I apply 2 or 3 drops of that soniclate on my mold, and then I let it flow across the area that I'm working there. Okay, I think that the quality of the seal is better as opposed to using this plastic bottle that Paulo did. But it's up to you to use one way or the other. So Paulo now is just removing the bigger parts of the knot, not to bother the patient. And you can see, super convenient and a fast procedure, no bleeding, very well adapted, as you can see there. So very nice and clean procedure. Exactly what Michael said here right now. Very nice and clean, exactly what I just mentioned. Now, Paulo is let the patient rest a little bit, and he's going to de-epithelize the graft outside the mouth. So the guys will change the position of the camera to focus on the connective tissue graft. We have that tongue depressor, which is sterilized, okay? That is a better surface to work on. So we like to use that to facilitate our procedure. And there are different ways of de-epithelializing the free gingival graft, but always using a 15C blade, which is new, okay? A brand new 15C blade to be very active. So no, it can be dull, okay? So if the tip of the blade touches anything, it's going to be dull. So we always want to use a brand new 15C blade to de-epithelize it. There are different ways of doing that. Let's see the technique that Paulo is going to use. He probably is going to try to slice it from the sideways, as you are seeing, like that. You can see sideways where is the epithelium, where is the beginning of the lamina propria. So he can put pressure on top of that and slice it from the epithelium towards the lateral. So that's one way of doing that. Another way of doing that is using another tongue depressor, put it on top of that connective tissue and making like a sandwich. So we're gonna have 2 tongue depressors on each side. I mean, like a sandwich, okay? And inside the connective tissue graft, and putting and looking sideways, we can dissect it laterally. That's another way of doing that. So Paulo is doing the regular way, which is that. So one side, then he goes to the other side. What is the challenge of this technique that Paulo is doing right now? Is to be sure that he removed all the epithelium, and it's impossible to tell. So we never know if we removed everything in terms of the epithelium there. So that is the downside of doing this technique, is that we never know if we removed everything from the epithelium. Okay, so if we leave behind some epithelium cells in that area, we might have the formation of like epithelial cysts inside at the recipient area, and that create like pinballs in that area. Okay, so specifically in the borders of the connective tissue graft. So that is the area that most we have this kind of remnants of the epithelium there. So basically, you have to be very careful and try to see. And after we finish, we'd like to go in the edges again, trying to remove a little bit more. I like to scrape it like shaving to try to remove the epithelium cells that might be there. But see that Paulo is very careful working in the edges of the graft. So that is the area that most we have, remnants of cells that are left behind. Now he changed the orientation of the tongue depressor to see if there is any remnant there. And it seems to be very nice. So what we have to do, how do we manage these pinballs? That's pinballs. I'm sorry, in this area. So what we have to do here, we have to anesthetize the patient if that happens. We have to anesthetize the patient and try to do like a gingivectomy in that central part. So basically, we're going to cut the epicenter of that area, okay? Like 1 millimeter or 2 of the area around the pimple, and probably it will heal. That is how we manage that, okay? So removed the connective tissue graft, de-epithelialized. So the sizing of it again, so in terms of length, it's going to be the base of the papilla to the base of the papilla. In terms of the width or the height, it's going to be like 6 millimeters, around 6 millimeters. And in terms of the thickness, in this case, between 1.5 to 2 millimeters. That is the dimension of the graft that he took, that he wanted to take to improve the possibility of having a very nice clinical outcome. Right? So he's going to position the graft in that area to check the sizing of it. See? From the base of the papilla to the base of the papilla, around 6 millimeters in height, and the thickness between 1.5 to 2 millimeters in the thickness. So in a tooth site, around 1 millimeter, that is just good enough. But for implant sites, specifically in the correction of a problem that is there, okay, which is a volumetric problem, the thickness would be like 1.5 to 2 millimeters. Is it still recording? No, it's recording, don't worry. So now the best part of it, which is placing the connective tissue inside. So we're gonna start the suturing in the base of the papilla, outside in. So we go in the base of the papilla, we're gonna leave in the gingival sulcus in that area. Now he's going to grab the connective tissue graft in the corner, Okay, so he did like a calculation, so where he wanted the graft to be positioned, and it's very important because if you miscalculate the height of the perforation of the needle in the graft, it can be more apical or more coronal. Okay, so it's important that to trick that procedure in the best way possible. And then he's going to come back in the pocket, in the base of the papilla, outside, inside out. So first, outside in, grab the connective tissue, and then inside out, in a way that now, with the both ends of the suture material in his left hand, see that he's pinching, he's holding the two ends of the suture material. He's careful not to rotate it, okay? And now, using his right hand, probably with a plier, tissue forceps, he's going to make it go inside that garage, as I like to say. So the connective tissue will slide from the buccal area of the garage, of the entrance, and will migrate towards the base of the papilla. And now he pulls it to the base of the papilla, kind of adapting that part of the connective tissue just below the papilla. So that is why it's so important to create a space, because if he doesn't create a space, it is impossible for him to really position the graft in that particular area. And now he's just providing the knot, not in aggressive way, so very gentle, but stable. Okay, this is a 5-0 suture material, so you can either use the 5-0 or the 6-0. Okay, Paulo likes to use the 5-0 for that. And he has to do that on the other side. So after he did that on the mesial, now he's doing exactly the same on the distal part, but being careful not to rotate or twist the connective tissue graft. So now see that he's using an instrument like in this moment, the periodontal probe, and going in the base of the papilla again, outside in, leaving the needle in the pocket, okay, that he created, an envelope. Now he is going to grab the corner, the other corner of the connective tissue graft. So he's fine-tuning the position there, being careful not to allow any twist in that graft. Now he has to go through the graft again in the base of the graft, in the corner. So he has to grab the connective tissue and make the needle go through. And of course, that now he has to make the needle in the base go from the base of the papilla inside out. The distance between where he started and where he finished in terms of the in and out of the needle should be at least 1 millimeter. Because if it is in the exactly the same spot, it can lose. And now with the two hands again, with the two ends of the suture material outside, with his left hand, he's going to grab it and pull. And with the tissue forceps, he's going to mobilize the tissue inside the pocket. So see that he's being careful not to have any kind of folding in the graft. And he's positioned that inside with the probe. And with his left hand, he's pushing some pressure in a way that he can work the position of the graft the way he wants. And it's very important that he observes that the connective tissue is stretched in the base of the papilla. Connective tissue in, you can see the border of it. And now he has to tighten the knot in a gentle way again, but firm. And to cut it. So with those two sutures, there are important sutures. He is stretching the connective tissue in the base of the papilla. Just a second. Just a second. Paulo. 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 Tem como colocar o espelho antes disso aí? Ah. So I was asking Paulo to show that with the mirror, but he's saying that he's just evaluating everything is good. So he's still going to show us the occlusal shot. I wanted you guys to see the occlusal shot prior to closing. So you can see that now the volume is better, okay? And it seems already that the gingival margin of that central incisor is even more coronal than the adjacent number 9. Okay, so the left central incisor, so number 9 for you, number 21 for us, is his reference, and the gingival margin of the right upper central incisor, number 8 for you, number 11 for us, it's even more coronal already. So that proves the principle that Virgilio did a good job in terms of the contour that he did, and the volume of the connective tissue is pretty much nice. So we can see the occlusal shot. Now we have a better volume there in that area. But I think Paul is still going to perform another suture. This is what I wanted him to show you. I wanted him really to remove the crown and show you guys the occlusal video, occlusal shot, so that you can see that we have a pocket, which is the tunneling or the modified envelope, and we have the connective tissue stretched in the mesial-distal aspect close to the gingival margin. And that is very important, because if you guys do not create a perfect envelope, meaning that you probably eventually not detach the base of the papilla, it is impossible that you can make the connective tissue where it has to be. So that is why it's critical to really be effective in the creation of the space in the base of the adjacent papilla. So it's important to put some pressure outside with the probe in a way that the base of the connective tissue doesn't move the connective tissue in the apical direction. Okay? So kind of putting the pressure on the graft towards the flap to create the space for the entrance of the crown in a way that it doesn't move or mobilize in the apical direction the connective tissue graft. So now he tied with the hand the area. It is clear that the gingival margin of number 8 is already more coronal than number 9. And see that there's no change in the height of the papilla, right? So we are working in the base of the papilla, of course, but our objectives in the buccal area. Now he's putting that protection inside the area, inside that hole. And of course, he's going to place the flowable resin there. And let's see if Paulo is going to perform the final suture. I assume he's going to use the final suture, which is like a sling suture around the contact points to put some pressure in the tissue in the coronal direction and stabilize that in that area to create the immobility that we need for the initial healing of that area. Now, just a matter of positioning this kind of resin or protection inside. So light curing, photopolymerization of that resin. And for many people, the surgery will be done already. But I assume again that Paulo still wants to use the final suture that we like very much to drag the tissue in the coronal direction and further stabilize it. Let's see if he's going to do that. The contact point should be okay for the sake of the stability that we want around the contact point. If he decides to do that, let's see. So a very clean surgery, as you can see. So it's important to put the pressure of the probe in the apical part to really be sure that the connective tissue is in the right position. And now he's going to engage the needle in the base of the papilla, grabbing the flap and the connective tissue simultaneously. And then he goes on the palatal aspect below the contact point. And just tighten the knot around the contact point. Simple as it is. So went from the base of the papilla to the palatal side, going through the flap and the connective tissue. And he can just now tighten the knot around the contact point. And you're going to see that by doing that, he will mobilize a little bit more the tissue in the coronal direction. So we don't want a big tension there. It's just good enough to create some pressure and stabilization, overall stabilization of the graft and the flap at the same moment. He's trying to also mobilize the knot towards the palatal aspect, okay, for the sake of visibility, so not so the patient doesn't see the knot, okay? But that is not very important. And then another one in the distal part. So the needle, the objective of it is grabbing the buccal area of the papilla. So in the base of the buccal papilla and the graft, and it goes to the other side. If in the way of going to the other side, it engages the palatal papilla, it doesn't matter. If it goes there, good. If it doesn't go, good as well. Because the anchor point, the anchoring point, is the contact point. And what really matters for us is bringing the buccal tissue in the coronal direction, okay? So if the needle passes through the palatal papilla, it is irrelevant. It can go through, or if it doesn't go through, it doesn't matter, because the anchor point is the contact point, and it's bringing the buccal area that is mobilized to the coronal direction, right? And now it's much more obvious that the tissue is even further more coronal than it was before. So that's a plus for us. We want, ideally, that in the end of the surgery, the tooth that is being treated is at least 1.5 millimeters more coronal than the adjacent tooth, so that in the future, Victor can play with that again if he wants, okay? But you can also see, it's quite clear to me here, looking at this image, then the gingival margin of number 8 is more protruded. It's more advanced in terms of the cervical region of the restoration, pretty much mimicking the natural appearance of a normal gingiva around teeth, okay? So it's not a butt joint anymore, because now it's covering the border of the ceramic. And that is so important for that visibility that we have the tooth coming out of the gingiva, okay? So it's coming out of the gingiva. So pretty much that's it. So now we're only going to do some pictures. For sure, we're gonna position those pictures for you at the WhatsApp group that you were invited as well, so that we can compare the beginning and the final the clinical pictures, the beginning and how it turned out. Okay. So I hope you have enjoyed. Thank you very much for being here. We're going to try to do that more often. Okay, so whenever I have the opportunity to perform live surgeries in the courses here, we're gonna always be inviting you so that you can see it as well. Okay, so thank you very much for being here, and please send us your thoughts on the procedure at the WhatsApp group as well. Okay, so I cut my mic here. I go there to see if the guys need anything from my side. And I thank you very much for your presence here. Bye-bye.